Imagine this scenario. A 3-year-old unimmunized boy from a suburban area in Tamil Nadu is brought to pediatric outpatient department with complaints of severe bouts of cough for the past 2 weeks. Initially, the child had fever, rhinorrhea, sneezing, and occasional cough for 7 days, and now it has become severe with repeated spasms more at night, and each episode is followed by a loud inspiratory oof and vomiting. So this is the classical case you are going to see in your question paper, which is regarding Bordetella pertussis. So let us talk about pertussis today. So this in 1906, scientists Bordet and Gengu found out that there are some small gram-negative coccobacillus. That's what it looks like, which is called as a fingerprint appearance. They are highly fastidious and they are non-fermenters. So they identified that as or named it as Bordetella pertussis. Then you have another group which is Bordetella pertussis, where the clinical symptoms and signs are somewhat similar, but just maybe slightly milder. Then you have the next one, which is Bordetella bronchiseptica, which is more of seen in animal infections. Pertussis is otherwise called as a 100-day fever, and it's a disease which is mainly mediated by toxins. The bacilli will attach to the epithelial cells in the nasopharynx. They will produce toxins which cause mucosal damage, thereby impairing the host defense, and it's a very highly communicable disease. Around 80 to 800% of people who are exposed might get infected, and 20% or so might get infected even when they are immunized properly. Maybe the signs and symptoms will be much more milder. This particular disease is most commonly seen only in human beings, and it's another example of a droplet infection, and it has to be in a very close range, so more commonly seen in infants and preschool children, and the patients, that is the people who are affected and in their prodromal stages, are much more effective in transmitting the disease than the proper infective stage itself. And even after immunization, you don't see a lifelong immunity. So clinically, you can divide it into 3 stages. There's a small incubation period of around 7 to 10 days, followed by a catarrhal phase, paroxysmal phase, and a convalescent stage. The catarrhal phase lasts for around 1 to 2 weeks, where the symptoms are more or less non-specific, like little bit of lacrimation, mild cough, fever, and malaise. And this is a stage where the patient is very much infective to others. And if you take a smear from the nasopharynx and if you try to culture it, it's a very highly likely chance that you will be able to see the bacteria on your smear as well as on the culture. This is followed by a paroxysmal phase, which can last up to 6 weeks, and patient is less infectious because, as I told you earlier, this is a toxin mediated disease, and the typical symptoms, the oof and the post-acid vomiting, are seen in this particular stage. This is paroxysm. It is about 5 to 10 repetitive episodes of violent cough. So with that cough, the lung capacities are exhausted and the patient tries to inspire a large volume of air against a closed glottis, leading to a particular sound. So this paroxysm will be precipitated by any kind of a noise, eating, or physical contact. And in between these episodes, the patient is pretty much normal, and most of the time this happens at the night. Slowly the frequency will differ, and whenever there is a patient is in this paroxysm, it can have visible neck vein distensions, bulging of the eyes, tongue protrusion, cyanosis, and there can be a visible weight loss, and the fever is not seen again, moving to the toxin mediated nature of the disease. Convalescent stage lasts for around 3 months again. Following the earlier stage, the frequency will slowly reduce and the antibodies start to develop in the serum. So what is it basically? You have these virulence factors. The first one is a tracheal cytotoxin, where it's a part of the cell wall peptidoglycan, which will damage the ciliary epithelium. The next is a pertussis toxin, which is of 2 parts, the binding area and the actual toxin part. The binding area will bind to the surface of the cells, make way for the second part, which goes inside and activates the adenyl cyclase and it can cause increase in mucus secretion, impaired phagocytosis, lymphocytosis, cough, and other clinical symptoms. Third one, the adhesins, which basically allow the bacteria to attach nicely to the epithelium. Apart from that, you have the adenylate cyclase toxin, dermonecrotic toxin, and bacterial lipopolysaccharides. Complications, when you see they are more common in infants, the pressure effects during violent spasms can cause subconjunctival hemorrhage, hernias, pneumothorax, rib fracture, or petechiae on the face and body. Complications can also be like when they are in an older age or due to secondary infection can happen, and if it occurs in infant, it's mainly due to Bordetella Pertussis itself. There can be some neurological complications also because of the lack of oxygen supply. There can be convulsions, encephalopathy, as well as coma. Differential diagnosis, when you think about it, it can be mycoplasma pneumonia, chlamydophila pneumonia, adenovirus infection, influenza virus, and rhinovirus. So how to diagnose? The basic method is a nasopharyngeal swab or a pernasal swab. The throat and sputum signals are not acceptable because of the normal flora which can be there. And generally try to take a swab. You take multiple number of swabs at 1 to 2 days intervals. And earlier we used to use a method what is called as a cough plate method, where the patient directly coughs at a culture media plate at 15 centimeter distance. Now that has been that is not being carried out now. So for swabs, use an alginate swab so that it can hold the bacilli for a much longer time. The PCR, you can use a Dacron or Rayan swabs. Cotton swabs might inhibit the growth of bacilli. So if at all you are planning to transport it to some other place, then the charcoal laden or impregnated cotton swabs, that is sword swabs, can be useful. Specimen should be processed immediately. You can use MES medium or the reagent low medium for transport. Direct detection you can do by direct immunofluorescence testing by using a fluorescent labeled polyclonal or monoclonal antibodies. Not used very widely because of its poor sensitivity and specificity. The culture is the gold standard, where the Bordetella Pertussis is a strict aerobe, grows best at 35 to 37 degrees. It will get fastidious bacterium requiring a complex medium. So finally the colonies come out as a greyish white convex with a shiny surface after 3 to 5 days. So these are called as a Mercury drop colonies or bisected pearls appearance. The culture will remain positive in the early stages of the infection and will become negative after 5 days of starting antibiotics. Then you take this gram staining, you will see a thumbprint appearance with a small overt cocobacilli which are arranged in kind of groups with the clear spaces in between. You can also use automated methods like Malditov or Vitek. You can also detect antibodies by using enzyme immunoassays or demonstration of IgG antibodies in paired sera, detection of IgA or IgM antibodies, which tells you about the acute nature of the disease. And the only problem with antibodies is it can also be elevated in people who are already immunized against the disease. Molecular method, you can use PCR for around first 4 weeks of infection. So you target the insertion sequence 481 and processes toxin promoter regions. And apart from that, you have a non-specific findings like lymphocytosis, which is common in young children. Treatment wise, the basic idea is to look at the cause, which is the toxin. So the antibiotics used here is to eliminate the bacteria from the nasopharynx, and once the infection is established and the toxin is produced in abundant amounts, it is not useful. You can use macrolides like azithromycin or erythromycin for 7 to 14 days. Cotrimoxazole is recommended in case of allergy to macrolides, and it is better to isolate the patient so that the precipitating symptoms can be avoided. Chemoprophylaxis for patients who are or people who are in close contact with patients will be erythromycin. For prevention of infection, you can use the whole cell pertussis vaccines, which was earlier used. So it has been the method where the bacteria are chemically inactivated and purified, and the efficacy was around 85%. This is what was used in the DPT vaccine as a whole cell pertussis vaccine given under the National Immunization Program. 3 doses you can be given along with, it can be also given as a pentavalent vaccine along with hepatitis B and H influenza, that will be given at 6, 10 and 14 weeks, and 2 booster doses at 1.5 years and 5 years. The pertussis component acts as an adjuvant and increases the immunogenicity of the diphtheria and tetanus components. Adverse effects can be fever, injection site pain, erythema, swelling, and irritability. Very uncommonly, patients can develop encephalitis or hypotonic hyporesponsive syndrome. It is not given in patients more than 5 to 6 years of age, and any chance of developing neurological disorders or a history of epilepsy, and when there has been a documented hypersensitivity to the previous dose of the vaccine. The next part is the Bordetella Pertussis vaccine. It is composed of the pertussis toxoid with 2 or more other bacterial components. It has a good efficacy with fewer side effects. It can be used in children with the age of more than 5 to 6 years and is available with diphtheria and tetanus toxin. Now, this can be given to children who have missed their primary dose of the DPT vaccine. This is in short about the pertussis. I hope I have made this short and understandable. Please do like and share my channel to your friends, and like my video, and please let me know of any comments you have in the comment section. Thank you.